Dr. Iton, let's just jump right in. I want to hear a little bit in a second about the California Endowment, but let's jump in with the big picture. We're going to be talking about health and community health and how people can thrive in communities. What do you find are the key ingredients needed to encourage and facilitate and ensure that people really can thrive in a community?
Well, Dr. Frist, thanks for having me. Interestingly enough, I think that people might find my answer a little bit unusual, and I'll give an example of why, I think that this is really critical. But, I've been working in this field for 20 plus years, and one of the things that we've discovered in this work is that health is really fundamentally about opportunity. And it's about real opportunity, also perceived opportunity. We spent about $1 billion in California over the past 10 years working in 14 low-income communities. And if I had to boil down what we've learned in that decade, it comes down to what I call ABC. A is for agency or power, or sometimes referred to as control. It's the sense that you have the ability to master the challenges that you confront in your day-to-day life. And, that's a very important skill at the individual level. It's also an important issue at the community level, so that the community can take on challenges that it faces. If they're facing a challenge that's environmental, or if they're trying to build a park, or if they're trying to get rid of liquor stores, they have the power to organize themselves and to take on a challenge and be successful at that challenge. So that's the A in ABC. The B is for belonging. And belonging means being connected, feeling that your voice is heard, that you're seen, that you're part of a community that values you. And sometimes I refer to belonging as the opposite of racism. It's really the sense that you are a full member of that society, and that society values your participation. And there are ways of creating belonging in communities that we've learned over the past decade. And then C of the ABC, if A is agency, B is belonging, C is for changing the odds, changing the fundamental conditions, particularly in young people's lives. And those odds are really shaped by core institutions like schools. And, for instance, the land use apparatus in that community. Are there enough parks? Are there opportunities for young people to explore their leadership? So are there recreation programs? Is there Big Brother, Big Sister? Is there Little League? Is there Pop Warner football? All those things that you and I grew up with, where we could just sort of walk out to the local park and, participate in some organized recreation. A lot of that has withered away, at least in California, and I'm told and have seen in other parts of the country as well. Young people find themselves pretty idle in the summer, and and after school, and we recognize that being engaged in a meaningful, constructive way in your life, particularly when you're young, that's all the way through the teens, is really critical to young people having high trajectories in life. So I said it would be a little unusual. The answer is ABC, agency, belonging, and changing the fundamental conditions.
And are any of those more important, or is any of those more important, or is it just all three together are? Is A come before B for a reason?
Well, I do think that, you and I are both doctors, and I think one of the things that, you realize as a doctor early on, that the patient who lacks agency, the one who just says, yes, doc, whatever you say, and then is not going to follow any of the advice that you've given them, those are the hardest patients to actually treat and maintain their health because they're passive. What you want is a patient that is engaged, who cares about the outcome, who's a partner with you, who's using you as an expert guide to well-being. It's the same thing with communities. We want communities that are engaged and feel that they have some control, some ability to master the challenges placed before them. And they can learn that by working together. They can be organized and they can participate, starting with small acts like getting a stop sign on a corner or a sidewalk or cleaning up a park. But over time, as they develop that sense of control, there's really no limit to what communities can do to better their own health.
And Dr. Iton, we hear so much today about one zip code being more important than your genetic code, or really just about anything else when it comes to health. Share with our listeners a little bit more about this and why place is such an important social determinant as we look at overall health and well-being.
Yeah, it's one of the more fascinating aspects of the research that I've done in health and public health and medicine. And it started when I was the director of the Alameda County, California Public Health Department. And I had gone to medical school at Johns Hopkins, and Johns Hopkins, as you probably know, is situated in one of the worst kind of physical communities in the United States. East Baltimore is a slum, and it's a pretty notorious one. And I was there in the 1980s, and it was during that time of the AIDS epidemic was flaring, crack cocaine was flaring, and I was very much stunned by the environmental conditions that people were living in. And I couldn't help but think that somehow those conditions were impacting their health, and that those conditions were not of their creation, meaning that I grew up in a very nice community and had resources and parks and investments in healthcare and education. And I was no different from any of the young people I saw walking around the streets of East Baltimore, insofar as I hadn't created the environment in which I grew up, nor had they created the environment of East Baltimore. And so it stuck in my mind, does your zip code matter more than your genetic code? Because I couldn't imagine people untangling themselves from those environments in a healthy way. And so when I became the health director out in California many years later, I still had this question on my mind. So I did a little research project where we had death certificates. I was the county health officer, so you're the registrar of all deaths, and there are about 10,000 deaths in Alameda County every year. And every death certificate tells you how old somebody was, what their race, ethnicity was, where they lived, and what they died of. So we took roughly 500,000 death certificates, and we did an analysis in Alameda County to look at patterns of death in the county. And what we saw, which was, surprising to many of my colleagues, my epidemiologic colleagues, but not so surprising to me because I had been in East Baltimore, what we saw was just in the city of Oakland alone, there was a 22-year life expectancy difference between parts of what we call the Oakland Flatlands, which are down by some of the bigger freeways, compared to the Oakland Hills, where there are some wealthier communities. And we couldn't quite get our brains around this idea that 22 years of life was in between, in some cases, contiguous census tracts or zip codes. And so we decided we were going to look at this question across the United States. And so we went to Baltimore, to Cleveland, to Boston, to New York, to Philadelphia, to Chicago. Everywhere we looked, we did the same analysis with health departments across the country. We found life expectancy differences on the order of, the smallest were probably on the order of 12 to 13 years, but you'd have 15, 20, 25, 30, in one case, over 30 years of life expectancy difference between neighborhoods in the same city. And those were not fluctuating differences. Those were stable differences. In fact, since we looked, and this was probably 10, 12 years ago, some of those differences have actually gotten worse. So this is sort of the pattern that you see in American cities. If you see sort of a similar life expectancy across the city, you're seeing a very unusual city. In fact, I have yet to find a city without a significant life expectancy difference across neighborhoods. So that is the American pattern. And what that told us is that, it confirmed that when it comes to your health, your zip code does matter more than your genetic code, because you don't see those kinds of fluctuations across genetic differences. You don't see, by the way, those kinds of fluctuations across behavioral differences. There's nothing that correlates with that kind of difference that explains those differences that we use as sort of a general understanding of what causes health. In other words, we say, well, behavior, whether you smoke, you drink, you drive without a seatbelt, et cetera. Well, that doesn't correlate with these differences. we say, well, some people have lucky genes, some people have unlucky genes. Well, that doesn't correlate with these differences. The only thing that really correlates with these differences is patterns of opportunity. And so that is the empirical way we've actually demonstrated that the closest association between these differences across cities. And again, we're not talking about a few months. We're talking about the difference between Afghanistan and Sweden in the same city. Those differences can only be explained by meaningful differences in opportunity. And those differences are both cumulative, meaning that it's the school system, it's the employment system, it's the access to potable water, it's access to recreation and healthy foods. So they're cumulative, but they're also synergistic. They all work together, interacting in a way that actually shortens people's lives. And there's a legacy of that that's passed on over generations in many of those same communities.
Our listeners who are policymakers and community-minded people and public servants, as they listen to that, it seems a little overwhelming. It's a little bit like your description in Baltimore itself. Where do you start? And you speak on this a lot, and you've written so much about it, and it's so much a part of your life. But when you sort of start taking it apart, where does a listener start? How do they put it in their frame of reference? Do they go back to the ABCs? They think of a particular project? Do they look at the purpose-built communities? We've on this and other podcasts, we hear about these purpose-built communities like in Atlanta. How did your typical listener in your audience respond to what you've just said?
Yeah, well, I think I find this personally very fascinating because, I'm a curious sort of scientist, and I just like to understand the truth behind these things. But there's some really good news in all of this. I mean, there are two other sets of facts that I think are relevant to this particular revelation. And one is that, we've had these so-called deaths of despair in the United States, which is, disproportionately happening amongst white, mostly working class, mostly rural communities. And we've seen, the scale of these deaths driven primarily by overdoses, alcohol in excess, and suicide. We've seen the scale of those deaths on the order of, the same size as the entire U.S. HIV/AIDS epidemic. We're talking about, over 500,000 excess deaths. In other words, 500,000 people who died prematurely who otherwise wouldn't have been expected to die. And so when you look at the root causes of that phenomenon, you see that they're also the ABCs. It's very similar. And I've come to talking about places like Scott County, Indiana, which, for a while had the highest HIV incidence rate in the world, higher than sub-Saharan Africa. And Scott County, Indiana, in southern Indiana, is 98% white. And to my mind, the factors that were driving the health crisis in Scott County, Indiana, were very similar to the factors driving the health crisis in East Baltimore, Maryland. Baltimore, you have a largely black population. Scott County, you have a largely white population. But fundamentally, the opportunity structures in both of those places were equally impaired. So I'll get back to that, but I want people to understand that this is not just a crisis of people living in inner cities. This is an American crisis, and it's manifesting itself across the entire income strata and across the demographic strata. So I think that, those are two phenomena that are important to keep in mind. But I think the good news is the third phenomenon, which is, equally fascinating. When we were working in Alameda County looking at life expectancy, we kept finding these outliers, these communities where you had very high levels of poverty, but very high life expectancies. And we couldn't explain it at first. And when we started to delve into those communities, in fact, we brought in some additional researchers, one from Virginia Commonwealth, a guy by the name of Steve Wolf, to help us sort of explain what we were seeing. What we concluded was in those very poor communities, you were seeing a very unique population of people who were mostly immigrants. And immigrants were the longest living people in Alameda County, despite very high levels of poverty. And in fact, we started looking at Latino immigrants, Asian immigrants, African immigrants, European immigrants. Each one of those immigrant groups outlived their native born peers in the United States. But as they acculturated and became more American, their health actually got worse. So you've got these three phenomena that are just fascinating. I mean, most people don't understand it. Your zip code is more important than your genetic code. These deaths of despair happening throughout, a major swath of the United States amongst white people disproportionately. And then this immigrant health paradox where very low income immigrants are outliving even wealthy white people throughout the United States. And so how do you tie that all together? And again, it comes down to opportunity. And that's the point I want to make, that you can tie all of these phenomena together in a fascinating way, and it leads to this completely novel understanding of what actually creates health.
The California Endowment, where you do all of your work, share with our listeners and our viewers what the California Endowment is.
Yes, the California Endowment is a somewhat unique organization, although there are a number of different foundations around the United States that are similar. We're so-called conversion foundations. We're a not-for-profit. In our case, it was a health insurer, Blue Cross of California, decided in the mid-1990s that it wanted to become a for-profit entity. And when you do that, under the laws of California and most states, you have to so-called disgorge your assets, meaning that your net worth is essentially a product of not having paid taxes. In the case of Blue Cross, they were a 70-year-old organization that had never paid taxes. So its value belonged to the people of the state of California. So in order for it to convert itself to a for-profit entity, which would benefit shareholders, it would have to pay back what it hadn't paid in taxes over those 70 years, which was essentially its entire value. And there's a long story associated with that. A number of consumer activists actually sued to force a full disgorgement of those assets. In the end, Blue Cross disgorged close to $5 billion, which created two foundations. One is the California Endowment, and the other one is the California Healthcare Foundation. The California Endowment is now worth just under $4 billion, and the California Healthcare Foundation is worth probably about $2 billion. So a significant amount of community assets were created. The mission of both of those organizations is to increase access to healthcare for all Californians and to improve the health status of all Californians. So we're basically a private public health organization whose community is the entire state of California. And we work very closely with other foundations like the Robert Wood Johnson Foundation, the Ford Foundation, Colorado Health Foundation, a number of other foundations that are kind of devoted to public health and improvement of the health status of the entire population.
So these conversions are fascinating, and they've been around for 20, 30 years, but our Nashville community understands them a lot because we have so many for-profit companies that over the years have acquired to improve nonprofit facilities and setting up these tremendous endowments. So thanks for that explanation, and obviously the good that goes on and on forever from an endowment like that is being manifest by our conversation today. Let me return to Nashville Health. So our survey was a community and well-being survey, the first in 20 years, and it was done by Nashville Health, and it was done by our Metro Health Department, and we had a number of people who contribute to it, and it was the first in a long, long time, as I said, 20 years, to give us a sort of status quo point in time in terms of our health. And the survey revealed all sorts of things, as you can imagine, but among them, deep disparities within our population, coming back to your references about the genetic code and many other disparities. And findings did clearly show that communities of color are not as healthy, the health disparities, which we know are across the country, as their white neighbors. Yet at the same time, they have this juxtaposition that Nashville, Tennessee, the surrounding area, is often called the Silicon Valley of health services. In other words, the home offices of services all over America, whether it's hospital or disease management or outpatient facilities, and all of really high quality. So people assume that people in the sort of 30, 40 miles radius of Nashville are all healthy. So this is a wake-up call. But explain to us a little bit about that sort of paradox that you see. Not peculiar to Nashville, but ironic because we are the so-called Silicon Valley of health services.
Yeah, and that's not at all unique to Nashville. I mean, as you know well, I started with the example of Johns Hopkins Medical Center sitting in the middle of East Baltimore, and for years that world-renowned medical center sat there, but the health statistics of the people who were living immediately adjacent to the hospital were actually among some of the worst in the United States. And similar to the Cleveland Clinic, and we have a whole host of institutions out in California where we see the same phenomenon. USC is another one, University of Southern California. So I think that one of the most important things for us to understand is that health services and health aren't necessarily synonymous. Not that health services aren't critical and necessary to populations that are experiencing disease, but one of my colleagues likes to say that just because aspirin cures a fever doesn't mean the lack of aspirin is the cause of a fever. So healthcare can treat disease, but does it mean that the lack of healthcare is the cause of disease? And what we've learned is that health has much more to do with, as I was describing earlier, these opportunity structures, the ability for people to essentially not need the healthcare system. The simplest example, of course, is education. And, we know that folks that can get a good education, get into college, maybe even get some postgraduate education are healthier than folks that don't. And there's a gradient, that correlates the amount of education you have with your health status in general. And that's not, an accident. The reason for that is that as you essentially acquire more education, you open up more opportunity for yourself. And opportunity allows you to essentially manage challenges more effectively than if you lack opportunity. But let me put it a little bit more simply. If I had to use one word to describe why we have entrenched health disparities, racial health disparities, income health disparities, regional health disparities, particularly with rural populations, if I had to use one word to describe why we have that, and people often ask me that question, I say I have the word for you. That word is stress. It's chronic, unremitting stress. And what you're seeing are people who are trying to navigate a complex world with relatively few resources, and they're constantly becoming overwhelmed. And what stress does is it stimulates a physiologic change in your body, chronic stress, which drives up a number of hormones, including cortisol. And cortisol is good for you in an acute, stressful moment. If a truck is bearing down on you as you're crossing the street, it stimulates your cardiac output. It causes glucose to enter your bloodstream so you can use it in your muscles and in your brain. It causes actually growth and development of neurons in critical parts of your brain that allow for you to make what's called executive decisions. Now, that's good in the acute moment. But if you're constantly stressed out, as folks in parts of Nashville, I'm sure, are feeling, folks in rural Tennessee are no doubt feeling, that chronic secretion of cortisol actually almost has the exact opposite effect on your body. That chronic stress causes hypertension, high blood pressure, and cardiovascular disease, independent of your diet or whether you exercise. The sad double whammy is that it also stimulates cravings for high-fat, high-salt, high-sugar foods. So you're craving the food and you're having direct physiological changes on your cardiovascular system. It also causes glucose intolerance and insulin resistance, which are risk factors for type 2 diabetes. And it causes changes in your brain that actually make it more difficult for you to engage in executive function. I mean, folks are in this constant fog of stress, and they're literally focused on the here and now, the immediate. They don't have the ability to put aside resources for the future or even think about the future. So I've actually taken to saying that low-income people in this country are actually physiologically different than high-income people, and not because they were born that way. although there is some intergenerational changes that can be passed on from chronic stress. So that is something that is also of concern. But it's not because they were born different from high-income people, but we make them that way through creating policies that generate unnecessary stress. And oftentimes it's the absence of policy in the face of abject need. I think that the most obvious one is health insurance. We're still unique amongst developed countries in the world insofar as we make it very difficult for people to have a regular, reliable source of affordable health care. And as a consequence, people have to worry about that. They have to worry about their children getting sick. They have to worry about their own illness. They have to worry about if they lose their job, they could lose their health insurance as well. So that's unnecessary. Most other countries in the world, you don't have that worry. You're not constantly concerned about it. We also have, for instance, I went to a very expensive private school, and I went to, a bunch of fancy colleges. I was able to do that essentially without having to, put my parents into, indescribable debt. These days, middle-class families just trying to think about, I have 4 kids. 3 of them have been through college. The amount of money that you have to set aside just to put your kids through just a basic undergraduate degree these days is substantial. Many people can't afford to do that. So it's another source of ongoing stress. So these are policy issues. I've just laid out, a couple very simple ones. There's a whole litany of other ones that generate for low-income people in this country chronic stress. And that chronic stress changes their physiology, makes them more prone to disease, changes their way of thinking, and it can be passed on in limited forms, to their children. So I do think that we know enough now in our research that we can actually make some changes. I should say there's also some very good evidence that you're very familiar with, I'm sure. Two health service researchers, Elizabeth Bradley and Lauren Taylor, wrote this book called The American Healthcare Paradox, where they showed that we always talk about how the United States, and this is a good case for Nashville, we spend disproportionately on health care in this country. We're the biggest spender. We're twice the average of other developed countries. And they show that while that's true, if you add per person spending on health care to per person spending on social benefits and social services, in other words, those kinds of investments that other countries make to make health care affordable and post-secondary education affordable. If you add those two things together, the United States is no longer the big spender. As a matter of fact, we're kind of in the middle of the pack of developed countries, excuse me. And the way that we're different is that we disproportionately spend our money on healthcare. So for every dollar we spend on healthcare, we spend about 55 cents on social services and benefits. In the European Union and in other developed countries around the world, Canada, Australia, New Zealand, they spend about, for every dollar on health care, on medical care, they spend about $2, twice as much on social benefits and services. And that's how they fund their, universal healthcare systems, and they subsidize post-secondary education and provide an array of employment benefits. So we could actually, without spending a nickel more, this point really has to be emphasized, we don't have to spend more money. We're actually spending enough.
And Dr. Iton, we've talked about that. You've been generous with your time and taught at our fellows class here at the Nashville Healthcare Council. And two things I have found in feedback and in discussions later that you're modeling your concept, your central organizing principle around cortisol or stress and the stress impact on cortisol really does resonate. And it allows people to think pretty independently, apolitically, loses the language that a lot of us hang on to, which has certain bias in it. When you look at that model, because we all know that stress comes from many different places. It's housing, right. It's education, it's bias, it is socioeconomic, it is racial, the stresses are there. But it does come back, as you said, and as you explained so clearly. So I just want to underscore it, that all of that comes into the body, through the brain, through the body, through our endocrine organs, with release in a very consistent pattern, these very, at times positive, but at times negative things. And I just want to underscore that for our listeners. You spell it out so clearly, but that stress is this common denominator that has a physiological impact that is beyond our control unless we can control the stress and go after the various levers. The second point I just want to underscore is the aggregate spending on the sort of social determinants, non-medical determinants, and the acute medicine. If you put it together, the U.S. is not spending very much, but we have to change that orientation. So my question is, and it kind of comes to COVID, if you're talking to a hospital administrator, or you're talking about somebody reimbursement or a physician providing care, they've got to provide the care, and they see a patient every 8 minutes, and they've got a hospital that needs to at least break even. So they have a hard time thinking, they themselves as individuals, to come on down the line to the non-medical determinants, to the basic things like food and shelter and education and housing and the even cyber access to cyber. They have a hard time doing it. What's going to change that, do you think, where all the big spend that's going on in sort of the delivery of medicine does come earlier on in these other determinants? What levers, what can the policymakers do? And in asking that question, has COVID made a difference? Are people paying more attention now, seeing the vulnerable people being disproportionately impacted, to pay more attention to these important non-medical determinants?
That's the billion-dollar or trillion-dollar question, if you will. I mean, it's really fundamentally, what do we want our health systems to do? What do we want them to be motivated by, to be incentivized by, and to ultimately deliver? And I think, and this is probably going to sound strange too, I think we ask too much of our healthcare delivery systems. I mean, I am of the opinion that we should ask them to develop and deliver a high quality, generally affordable healthcare product that improves disease as it sees, appropriately, and does it in a way that is non-discriminatory. I think that's all we should be asking our healthcare systems to do. But at the policy level, we need to create strong incentives for healthcare delivery systems to lean into community health outcomes. It should matter to the consortium of Nashville health delivery executives what the high school graduation rate is in Nashville. It should matter what the college going rate is in Nashville. It should matter what the obesity rate is in Nashville. It should matter how much sugar-sweetened beverage young people are consuming in Nashville. If those things don't matter, if you don't close that circle, sometimes we call it a system of prevention, where everybody has the same basic incentives, which is to drive towards health. If you don't close that system, you're going to have, very well-intentioned healthcare executives and doctors. I'm a physician. My goal when I see a patient is to advocate for that physician, for that patient. Come all, no matter what the circumstance is, I want the best for that particular patient. You want your healthcare systems doing that, but you want them to be incentivized beyond just that 8-minute encounter, as you described. You want them to be incentivized about the collective health of the community that they serve. And you want their pay to, at some level, be contingent on their ability to add value to the overall health of that community. And that's something that we just don't do in this country. We just sort of look at healthcare delivery systems and we ask them to, why don't you care about the social determinants of health? You should care about social determinants of health. Well, their current incentives now are to keep their beds filled in the hospital and to essentially optimize the service lines that generate the most revenue, because many of them are operating under relatively thin margins. So they're struggling just to compete, in a place like Nashville or in Houston or in San Francisco. So now you're asking them to essentially forego that fundamental prime directive of survival in order to focus on the social determinants. Well, the good ones will say, yeah, I understand. I know what you're trying to say, but that's not my business. My business is essentially a bottom line business where I have to actually provide for the shareholders, the physicians, the nurses, all of the folks that work in my hospital. And that's not about the social determinants of health. That's about, essentially providing services. So I think, and this is not rocket science. I mean, we have very smart policymakers who understand that. The key is to create the right kind of incentives. And that's where COVID comes in. I think in this particular moment, we saw, COVID, with a relentless force, just crash our economy almost overnight. I mean, it just took it down at the knees. And at the end of the day, if you're being completely honest about why that happened, it was because we didn't have a meaningful first line of defense. We didn't have a meaningful public health infrastructure to essentially prevent what we knew would happen someday. We all talked about that pandemic preparedness. But because we disinvested in that prevention infrastructure, our first line became emergency rooms and clinicians who are not really the first line in the pandemic. The first line should be public health. And so we're paying the price now for not investing in that infrastructure, and it's crippling our economy, and it might take our economy down yet again as these cases continue to surge. So the lesson to me, and I think to smart people that you work with in Nashville and all over the country, is that if we want to get this right, we need a meaningful first line of defense in public health. And that's going to help us in COVID-19 or the next pandemic that comes around the corner. And it's going to help us with obesity and chronic disease and opioids and the rest. So we have the accent on the wrong syllable, as I like to say. We have it all on sort of like the downstream emergency room, which we're the best at in the world. I was trained at one of the best institutions in the world. I am so absolutely, I feel so privileged to have gotten that, that high quality scientific training. But it also taught me to use my analytic mind when looking at a problem and try to work my way through it. And when you do that, you're forced to come to the conclusion that we don't have an adequate infrastructure of prevention in this country. We're paying for it in the emergency rooms and the ICUs. And COVID-19 is a perfect example of what happens when you don't have that first line of defense.
We need to make this, and hopefully our discussion today is part of that, a teachable moment. And that does require policy changes. And it does require a rethinking. You're more familiar than I, but over the last 10 years, our federal funding that ultimately comes down to putting boots on the ground in places like Nashville or counties around the country and in our states has fallen by about 22% in terms of the money that goes for people and infrastructure and epidemiologists on the ground. And that's inexcusable. That's just a part of the public health infrastructure that you're talking about. But with a pandemic, again, using this as a teachable moment, and we've had 14 pandemics in the last 100 years since 1917, 1918. Pandemics will continue to come back. Viruses will continue to emerge. We're in the middle of one now. And it is almost, I'll say criminal, but all of us are at fault. And the American people have to step up and demand a stronger public health system. It's not the hospital systems to be blamed, and it's not the doctors to be blamed. We as a society, through discussions like this, but we are unfunding the basic infrastructure of public health and well-being. And I think COVID is clearly, when you look at, basic things, and here in Nashville, blacks, African Americans make up about 17% of the population, but comprise about 33% of all the COVID-19 related deaths. And that's not unusual to hear. It's all over the country itself. When you start looking and peeling it back, you look at this lack of integration that you're talking about and that you explained so clearly. Let me move to a couple of other statistics, because I was looking at our Nashville Health and Wellbeing, Community Health Wellbeing Survey, which is just recently out, and we found that 4 times more Black respondents than white respondents reported recently feeling emotionally upset how they were treated just based on race. This is in the healthcare system. And you've written and spoken about this whole impact. We've talked about this whole stress, cortisol in one's body. Does that relate there? Is that a potential example of that?
Yeah, that's a beautiful example of it. In fact, racism, and I think that one of the challenges of racism is that we oftentimes think, okay, if there's racism, there are racists, and we individualize it, and we don't actually look at some of the structures or the legacy of past policy. And I think that this current movement right now is doing a good job of trying to tie the sort of the immediate present day effects of police brutality to structural racism and the legacy of past policies and practices. So oftentimes people think, well, I'm not a racist, and I don't believe in sort of white supremacy or what have you. So why are you attacking me? And I don't feel like I have any privilege either. I think we need to sort of take the conversation to another place to look at structure. And structure is what we were talking about earlier. It's really opportunity structures. It's the ability of people to essentially use their God-given talents in a way that where they can take opportunity and exploit that opportunity to the benefit of them and their community. And what we have right now are we have differential kind of levels in terms of people's ability to sort of pursue opportunity. It's very racialized, but it's not exclusively racialized. And this is part of what you're seeing in rural white America. You're seeing meaningful opportunity barriers to folks that are trying to express their God-given talents. So I think sometimes we create this racial dipole of black-white, when in fact it's much broader than that. These opportunity barriers sort of run across society. Okay, so is stress at the root of that? Absolutely yes. Which is one of the reasons I try to simplify this for people, and I say, I'll give you one word that explains everything, and it's stress. If you give me 2 words, I would say it's chronic stress. Those are at the root of that, and we all know it. We all know it, intuitively within our bodies. Those moments in our lives when we really felt like we couldn't do something that we felt like we really had talent or skill to be able to do, and we were being denied the opportunity to express that, that is very stressful. Now just imagine that when you're thinking about it in terms of how you look, your skin color or your gender or your religion or what have you, that you're being denied that opportunity, something that you can do, and you feel like it is really your essence, and you're being denied that because of the way you look. Think of how that would feel. I mean, that feels like incredibly frustrating and soul crushing. Well, that's what's happening to people, in urban inner cities, in rural communities, on Native American reservations today, all throughout the United States, and it's unnecessary because that's talent, that's sideline that we could actually use to compete with the rest of the world. We're wasting resources in the human talent that we're sidelining because of their race or their gender or their ethnicity or what have you. So again, stress goes right to the heart of this issue, and it's unnecessary. These are stressors that we created, again, through policy. I sometimes refer to it as policy violence. It's the absence of affirmative policy in the face of abject need. And we see that all the time, where we see I was at a high school in upstate New York a couple of years ago, and I asked the folks that were organizing the conference, well, what's the high school graduation rate here? This was somewhere just outside of Buffalo. And they told me that the high school graduation rate for African Americans in that school system was 19%, meaning that 81% of the kids didn't graduate high school on time, 80 of the black kids. And I said to them, 19%? That's not an institution that's performing. You should throw that whole institution out. I mean, the majority of kids that it's designed to serve are not getting the fundamental outcome of that interaction. That's not a high school. That's something
Yeah.
other than a high. That's
Yeah.
policy violence.
Yeah. No, listen, this is so interesting. And just looking at the survey here, I just kind of going through the findings in the Nashville Health Community Survey, and here is that there are 5 times more African Americans perceive discrimination when seeking health care. And that's here in Nashville. That's within, 8 miles of where I'm sitting. A survey of 10,000 people responding, statistically fantastic. But 5 times more blacks perceive in that interaction with the health community discrimination while they're seeking health care. And again, just in your explaining it to me, it hits stress, it hits cortisol, it hits chronic stress, and all of which is destructive if in the wrong environment. And it does begin to fit together here. And I think your point about the discrimination and the stress, it's not just racial. Racial is where a lot of the focus is now because of recent events and every community and is discussing it like we are now. But it does apply to rural health, to cultural health, to other vulnerable populations today. And as we've seen, the COVID virus has hit all vulnerable populations, whether it's race or gender or ethnicity or socioeconomic or where people live. They have been hit disproportionately, and that really does expand this whole discussion of discrimination, of structural, we call it racism. It could be structural discrimination. And it's an exciting time to be able to go back and look at that and self-reflect and have dialogues like we are, but dialogues in a diverse environment to address these levers. Putting a lot of this together, I know we need to wrap things up. You've said, I've heard you say so much, that for policy to change, the narrative must change. So how do you see changing that narrative for our listeners?
I'm very privileged to be able to do this work, and it's fascinating. And I just love having these conversations because it really is about trying to get to the root of the truth. And I think that, one of the things that you see in this country, in the United States, it's not unique to the United States, but it's, you see it particularly exacerbated in the United States, is that we have these competing narratives. During World War II, this country came together, to build the sort of the machines and all of the logistical support for our soldiers that were fighting overseas. After World War II, we built the interstate highway system. In California, we built probably the world's best public post-secondary education system, and many other communities did the same. We built, infrastructure. When this country wants to come together and sort of use its sort of collective, resources to invest, it's second to none in the world. But we also have this competing narrative in this country of what I would describe as hyper-individualism, that, pull yourself up by your bootstraps, government is bad and suspect. And at the end of the day, things looked much better for us in the past, and the future is kind of scary. And I feel like there's competition between that narrative, which is at its heart, that hyper-individualistic narrative basically blames people for the struggles that they have. If you haven't done well, it's because you've done something wrong. And so, folks could say that to African Americans in parts of Nashville who are struggling. Well, it's your fault. It's your culture. It's your behavior. You've, not had enough children. You've got too many single parent families. Let me just say that it's never completely untrue. There are factors that actually make it harder for people to be successful. But more often than not, these two things are inextricably intertwined. I mean, folks' inability to essentially navigate a healthy environment. I use the example of young children who are trying to find healthy food in food deserts across the United States. They're exercising the best personal responsibility that they can in those circumstances. But there's no collective societal responsibility to help them essentially find the resources that they need. So they struggle. And over time, they get frustrated. Their stress levels go up. So you've got individual responsibility nested in social or societal responsibility. Those two things are inextricably intertwined. Too often we draw like this dichotomy between personal responsibility and societal responsibility. And that is because there are these two narratives. And both of the narratives are true at some level. The only question is, how much do you need them to interact in order for us to be successful? Yes, it's true that people who work hard, play by the rules, will tend to do better. Now, those rules actually have to be fair rules because there are a lot of people working in parts of Nashville that are low income, African American, working hard, playing by the rules, the majority of people, in fact, and they're running into barrier after barrier after barrier. And that's because of the lack of social or societal responsibility that actually invests in them as well as other people. So I do think that at the end of the day, we have to decide who we are and what our values are. And it's not just one extreme or the other. It's not socialism versus capitalism. It's about who we are collectively and how do we best function when we're actually investing in each other. And to my mind, I think that the COVID-19 pandemic demonstrates to us that we can't do this alone. Our fates are inextricably intertwined. We do better when we all work together. And when it comes to health, that's the narrative we have to understand. We, the collective we, is what will actually shape our health. It's not just I, it's we. And so at the end of the day, that's the lesson that we're trying to further at the California Endowment in our work in California. We think we've made substantial strides in improving the collective health of the state. Some independent measures empirically show California's health to be number one, or at least, in the top 5 in the country. And we think that has a lot to do with the narrative here of we work together to invest in each other.
The narrative is clearly important, and I think, or my gut feeling is, and just circulating among people and talking policy and health and well-being and acute delivery of healthcare and prevention in public health, is that the COVID experience is as painful as it has been, especially on the vulnerable populations, does have a few silver linings. And you hate to say that because people are suffering so much from the unemployment from the virus itself, but a few silver linings. And I think that narrative is one. A teachable moment and awareness that we are all in this together. This virus is indiscriminate. It doesn't need a passport. It's in every community. We're all at risk. And it causes us to look inside and to say, what is our most powerful incremental impact we can have? And that is coming together, addressing it together. And I just think people are feeling that. And it's clearly what the larger movement that we've been talking about, the pre-existing COVID that you and I have talked about in terms of the whole approach to health and well-being more than healthcare. But I think it is accelerating that movement. And at NashvilleHealth, where we are built around the collective, NashvilleHealth, our community coming together as a collaborative, as a collective in the same way, tries to bring together all of these issues. And in the future, we'll use things like your central organizing principle of the chronic stress, because it's so crystal clear to me. It's right, it's physiologic, it's understandable, and moving forward. So collaborative, collective, just as you're doing in California and around the country, as COVID, I think, is stimulating and giving us new opportunities. And as we're doing at NashvilleHealth, I end up being pretty optimistic about the future. Dr. Iton, thank you. Thank you so much. And, as always, for you and for me, this is an ongoing conversation. And to be able to share it just like this in a conversational way with our thousands of friends around the country. So many of the issues we talked about, we do mention in other podcasts. We've talked with Dr. Shirley Franklin at the Purpose Built Community, talked to Dr. David Williams, who is I think his podcast is in a week or so, about so much of what we touched upon today in terms of the science and these sort of uniform channels there. But you, better than anybody, kind of put it all together in an understandable way. So I do want to thank you on behalf of Nashville Health, on behalf of the people of Nashville, and on behalf of all the tens of thousands of listeners who are listening to us right now. Thank you for being with us.
My pleasure, Senator. Anytime. Thank you.